So in our clinical encounters, when we see patients in clinic, we have 15 or 30 minutes to see a patient. And a lot of gaps in information can be caused because there's so little time and so much we have to go over.
That's Dr. Samuel Washington from the University of California, San Francisco. We'll have more from him later in the show. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Bladder cancer cases are on the rise, and at the same time, persistent disparities make it difficult for patients to access care. Our guests today will talk about the challenges and reducing those barriers. Dr. Samuel Washington is a urologic oncologist, an assistant professor of urology, and associate chair of DEI at UCSF in San Francisco.
So the key insights from our phase 1 analysis was that there are major gaps in guideline concordant care for all bladder cancer patients, particularly populations that are already facing disparities. We also found that there's a great need to build awareness about disparities, as well as moving beyond observations, but also action to mitigate disparities. And that action should involve care coordination between oncology, urology, to really understand how we can improve timely referrals, so avoid delays in care due to the referral process. We also found that financial advocacy and social support services are necessary, particularly given the cost and burden associated with bladder cancer, especially cancer that is more advanced and requires more treatments and medications. Additionally, we found that there's a lack of shared decision-making training specific to bladder cancer for healthcare providers. So because there's no standardized approach and coordinated opportunity for measurement, it's difficult with the tools we have now to really standardize training across the board. Lastly, from these analyses, we see that there's much more information needed. And this is really an opportunity for case studies, qualitative work, as well as step-by-step guides to start to standardize the care that is provided to patients afflicted with bladder cancer.
Dr. Washington, can you share some effective health literacy practices for those patients with bladder cancer?
When it comes to effective health literacy practices, I think the first step is really understanding the difference between literacy, so how comfortable people are reading and the reading level, versus health literacy, which is almost a separate language of medical jargon and terms. And we have to understand that those two things don't correlate or aren't a one-to-one equivalent comparison between the two. So the first step to understanding health literacy or competency and understanding medical jargon is to really measure or assess a patient's health literacy to begin with. So we do that often through making sure that any materials that we give to a patient are at a very lay person level of communication. So we're avoiding a lot of medical jargon, medical terms, brand names for medications, for example. And that allows us to make sure that we're communicating with patients better, but it also requires teach back. So having a discussion with patients rather than lecturing them, making sure that we stop throughout the conversation to get a sense of whether patients understand what we're talking about. And sometimes we'll have them even repeat that back to us so we can truly get a sense or an idea of how much of that information is being retained. Because we know at the end of the day, patients remember roughly 20 to 30% of what we say. So we really have to stop and engage patients throughout the conversation to give ourselves a check that we're communicating well and that patients are able to hold on to that information.
What should shared decision-making conversations look like, and who should be included in those?
The ideal for shared decision-making is that the provider, whomever that is, and the patient are truly having a conversation and coming together to find the best option for that patient. And that really requires, again, a bi-directional opportunity for communication. And I think a lot of the times when it comes to discussing bladder cancer, what the care looks like, what the costs are, what the burden may be moving forward, that may be a conversation best had between the provider, the patient, and their partner, significant other, or other social support people that they have in their lives to truly understand what that burden would look like, not just tomorrow and the next month, but the next 90 days, the next year, 2 years, 3 years. So people have a clear expectation of what each option would look like, both in the short term and long term.
How do we make sure patients with bladder cancer are receiving the best possible care?
This is a tough question because I think we always look for a one size fits all answer. And I think conceptually, we all understand that there is no one answer for each person or each clinic. And I think conceptually, we all understand that my patients that I see in San Francisco may be different than patients I see in Texas or in New York for reasons that are really specific to where patients live. So I'd say for providers, it's really first understanding what's happening in our own patient pool. So if we notice that there's a difference or there are problems that multiple patients have with getting BCG or getting chemotherapy of some kind, that really requires us on the provider side, on the organization side, to start investigating that in our patient pool, in the population of patients that we are treating to understand what those problems are. And once we have that needs assessment, that idea of what the barriers are, then we can start tailoring our action and our efforts, our energy and our resources directly towards those barriers so we can help the largest group of people possible who are all having the same burden.
How can we address and change potential assumptions like implicit bias about patients?
At the end of the day, bias fills the gap in our knowledge is the way that I think about it a lot of times. So in our clinical encounters, when we see patients in clinic, we have 15 or 30 minutes to see a patient. And a lot of gaps in information can be caused because there's so little time and so much we have to go over. So I would argue that ways for us to avoid bias and fill the gaps would be asking some of these questions beforehand. So one example would be where I work currently, we have started to integrate questions about transportation barriers or financial toxicity or food insecurity. So we don't need to make assumptions because we are now asking patients to give us some of that information up front. Now, we know that 100% of patients will not feel comfortable providing this because it is very sensitive information, and there may be concerns that we may not get 100% accurate responses from those who do. But it does give us a pulse, an understanding of what's going on we may not have had beforehand, and we may have assumed incorrectly based on our own biases.
Dr. Washington, there are upcoming ACCC quality improvement workshops and an interactive e-course on implicit bias. What should we expect to learn in those?
So all of these issues that we understand with bladder cancer, addressing implicit bias, understanding health literacy, really drove the efforts around creating a quality improvement program to understand what's happening at the clinic level. So within an organization to improve care for the patients they're seeing. That was really the driving force of the ACCC Quality Improvement Initiative to address disparities in bladder cancer care. Through that program, we'll be able to explore and identify disparities or gaps in care, and then start to generate and offer multidisciplinary and shared care management approaches tailored to that clinic or that institution for them to address the burdens that are afflicting their patients the most.
Next, we turn to Mary Dunn on the patient impact. Dunn is an adult nurse practitioner of urology and medical oncology at the UNC Lineberger Comprehensive Cancer Center in Chapel Hill, North Carolina.
When we're using shared decision making and putting the patient at the focus, I think it helps them feel like we're listening to them, that we genuinely care about their needs and their wants, and it creates a more trusting environment and creates a more trusting relationship between us and our patients. And I think when you're dealing with something that is as delicate and difficult and potentially traumatic as a cancer diagnosis and cancer treatment, ensuring that the patient knows that their voice matters in the treatment decision-making process is huge. And incorporating what their goals of care are. Do they want to take treatment? Do they want to get a second opinion? Do they want to be away from home for hours on end to come and get infusions? These are things that we need to make sure we're talking to them about, and what they are looking for as far as treatment and how it might affect their quality of life. So kind of intertwining the shared decision making when it comes to treatment plans, but also when it comes to goals of care, to ensure that what the eventual treatment that we line up for them also matches what their goals of care are.
Tell us a little bit more about the importance of engaging in maintenance therapy.
So for folks who have had potentially neoadjuvant chemotherapy, so chemo prior to having a radical cystectomy, then going on to radical cystectomy, depending on what their pathology looks like after cystectomy, might be candidates for maintenance therapy, depending on what they got pre-treatment and what their pathology looks like. And I think shared decision making is really tied into that as well. So that's kind of a nice segue, because that's a commitment people have to make. That's, more travel time to their cancer center to get infusions. Even if we think they're good candidates for it, we never want people to feel like we're making them do something that they don't want to do. And typically I see about a 50-50 split when it comes to maintenance therapy. Folks who say, absolutely, throw the kitchen sink at me, I want everything. Or folks that say, you know what, I've been through chemotherapy, I've had this major surgery, I really need a break. Can I just go on surveillance and come back in a few months for scans? So I think weighing the pros and cons of what that looks like for each individual patient is a huge part of the discussion.
What about female patients? Are there disparities you see with bladder cancer?
Yes, and unfortunately, I have several stories. One of the biggest disparities that I've seen in my practice is delayed diagnosis. And what that typically looks like is I'll see a new patient for a hematuria referral will come in, and you go through their history with them, and it can be a combination of several things. So one, sometimes patients don't listen to their bodies, right? They may have seen the blood in the urine, the hematuria 6 months ago, but thought maybe, hey, this is just part of my menstrual cycle if they're still having menstrual cycles, or maybe this is vaginal bleeding or some sort of menopausal thing, and just kind of brush it off and ignore it. Or, oh, maybe I have a urinary tract infection. But then the other component to that is women who seek care for their hematuria and are treated for urinary tract infections that aren't in fact urinary tract infections. It ends up being a cancer diagnosis, or they're just not heard. And a urinary tract infection and bladder cancer can be happening at the same time. So if someone is diagnosed with a UTI and they still have symptoms after they finish their course of treatment with whatever antibiotic choice that is, then that should prompt people to think about, could this be something in addition to a UTI? So delayed referrals to a urology provider can certainly lead to a delayed diagnosis. And we know with that can lead to women being diagnosed at later stages, which is something that unfortunately I've seen a lot of times in my career.
How do you hope we address disparities in the future?
I think that the list of disparities is enormous, and it's heartbreaking sometimes. I work at a big academic medical center, but we see patients from all over the state. A lot of folks are of lower socioeconomic status, which can lead to all kinds of hardships, such as financial distress, transportation, childcare needs, all kinds of things that can lead to delays in diagnosis and delays in treatment. So I think that as far as disparities, especially for our female patients, screening for those types of things at the time of diagnosis could be beneficial. So screening for financial distress, screening for transportation, seeing if people have caregiver support and all types of things, just to ensure that we're supporting our patients not only with the treatment that we're giving for their cancer, but also with the socioeconomic factors that might be impacting. So I think if we could do a better job of doing those things, we might be able to help people more. And I think also that we need to be doing a better job of educating our fellow healthcare providers about when to refer to urology. So something that stuck in my head from a very long time ago when I was in nursing school is blood in the urine is bladder cancer until proven otherwise. And for whatever reason, that's always stuck around in my head. And I think if we could do a better job of educating, let's say, our primary care provider colleagues who do tremendous work and our gynecology colleagues who also do tremendous work about when is the appropriate time to make that referral to a urology provider to look into that hematuria further, I think would be crucial too, as far as disparities or delays to diagnosis are some of the things I think about.
Thank you to our guests today. You can head to the show notes for more resources on shared decision-making and health literacy techniques. ACCC has a new project called Addressing Disparities in Bladder Cancer Care. That's focused on evidence-based health literacy and how to approach shared decision-making. You can find more about the project in the show notes. Until next time, this is Summer Johnson.
This show is a resource of the Association of Community Cancer Centers.